Let me go ahead and get started. So what I'm going to do here today is touch a little bit on kind of latest advances in CMR techniques and also kind of highlight where I think the field is going in the future. So let me just skip forward. So obviously, if we look back in time, 20 years ago is when the initial delayed enhancement MRI technique was first developed. It was 1999 when this initial publication came out, showing essentially the ability with MRI to directly image myocardial infarction. And I think obviously what's unique is the ability to not just see that there's an infarct, but to get almost an exact match to what it would look like histologically. Now, and obviously, numerous validation studies have shown that using the delayed enhancement technique is able to identify likelihood of improvement in contractile function. In this New England Journal publication, this was after coronary revascularization, either with PCI or CABG in patients with chronic CAD. And I think one of the unique findings obviously was that the predictive value of the technique not only held up, but actually got stronger when you looked at greater levels of dysfunction at baseline. So if you look only at those segments that were akinetic or dyskinetic, both the positive and negative predictive values are even stronger. And really, I think, established over the last 20 years the fact that there's this inverse relationship between the extent of hyperenhancement that you see and the likelihood of improvement in contractility. And that relationship seems to hold true in the setting of chronic CAD, also in the setting of acute coronary disease, as you can see the same inverse relationship. And in fact, also with just medical therapy in patients that have chronic heart failure who are getting beta blocker therapy, again, you see the same inverse relationship. That as you have more hyperenhancement within a given segment, the likelihood of improvement of that segment decreases. Now, so what I want to touch on is kind of what's new in the last few years. One, obviously, is that within a specific subgroup of patients, I think MRI is really has the potential to shine, and that's in patients who have a significant wall thinning. And here's an example of a patient who has an anterior wall and apex that's very thinned out. It's about 4.5 millimeters in wall thickness, and this person has significant LV dysfunction as well, with an LVEF measuring about 30%. What's interesting, however, when you look at the delayed enhancement MRI technique on this patient example, you can see that there's actually very little in the way of hyperenhancement, despite the fact that the wall is thin and the amount of black or viable muscle is very little, but the amount of hyperenhancement, in fact, is very, very minimal. And this is an example of a case where there's wall thinning with yet very limited scar. And in this scenario, how often does this occur? Well, in fact, when we looked at this, we found that this may occur in about 20% of patients who have wall thinning. And if you look at the relationship between wall thickness and the extent of scar within any given area in the thin myocardium, there's a relationship, but it's fairly loose. You can see a fair bit of scatter. And what was really predictive was, in fact, the presence or extent of hyperenhancement. And you can see in this example case, when this person went on to get revascularized, that thinned anterior wall actually manifested, let's see if this will play here, an improvement in contractility. As you can see here, you'll notice the EF went from 30% before to an EF now of close to 50%. So showing, in fact, that you can have significant functional improvement despite having thin myocardium. And in this publication, when we stratified it by less than 50% of the thin wall showing hyperenhancement or more than 50% showing hyperenhancement, essentially all patients with less than 50% hyperenhancement in the thin wall, i.e. those with limited scar, actually showed an improvement in contractility, whereas those with more than 50% enhancement showed really no improvement in contractile function. And furthermore, I think what was also striking was if you look at the thickness of the wall, it actually also improved as well. So you went from an anterior wall, which is 4.5 millimeters in wall thickness, to one now that's almost 9 millimeters in wall thickness after revascularization. And when we looked at our series here, also we noticed that for those patients that got revascularized with very little scar in the thin wall, they actually saw an improvement in wall thickness compared to those patients who had significant scar within the thin wall, where the wall thickness did not change after revascularization. And so I think, at least for this one subgroup of patients, CMR may be uniquely suited in identifying patients who have the potential for reversible wall thinning. Now, let me talk about some newer delayed enhancement, or kind of, I guess, second and third generation delayed enhancement techniques. So one of the challenges, obviously, is when we're looking at, with the delayed enhancement technique, the myocardium is black and areas of scar or infarction are bright, but oftentimes they can be superimposed or adjacent to an area of a bright cavity, right? So one of the things that we typically will do is try to wait 15, 20 minutes after we give contrast to hope that the blood pool signal goes down. That's fine, but sometimes when you have a busy clinical service, you may not be able to wait 20 minutes. And so that's when there's been work done really in the last couple of years to try to develop techniques where we can actually suppress the signal of the blood cavity. And so this is basically what's called a dark blood delayed enhancement technique. So this is showing, in fact, before we had the dark blood technique, the only way to get the blood pool signal to fade away is to wait. You can see here, myocardium is black, the infarct here is bright, but the blood cavity is very bright. And this is actually 5 minutes after contrast administration. If we wait 10 minutes afterward, you can see now the blood signal starts to fade away a little bit. So the contrast between the infarct and the cavity is a little bit more. And if you wait 20 minutes after contrast administration, you can see the cavity has faded even further. So now you have a much greater contrast between the infarct and the cavity. But now, with the newer technique called dark blood delayed enhancement, you can actually completely suppress the signal within the cavity without having to wait for the 20 minutes. And as a result, it makes it very easy to identify the presence of a small subendocardial infarct. I think the previous case highlighted an example where you can see the infarct pretty well, even on the standard delayed enhancement. If I show you this example right here on the left-hand side, I think it's hard to be able to appreciate that there's an infarct present here in the septum. If you just look at the standard bright blood delayed enhancement technique, you can get a hint of that because you say, well, look at how thick the myocardium is here in the lateral wall, but look at how thin the black myocardium here is in the septum. But again, when you use this delayed enhancement technique and you completely suppress the signal from the blood pool, all of a sudden you can very nicely appreciate that there's a subendocardial infarct that's present here within the interventricular septum. And another application of this technique is, in fact, for looking at the papillary muscles. Because obviously the papillary muscles are sitting within a sea of bright, which is the cavity. And if I show you the standard delayed enhancement technique in this patient example here, I think we could be hard-pressed to say with certainty that there's any papillary muscle abnormality. But again, now, if we look at a dark blood delayed enhancement technique, you can very clearly appreciate that there's papillary muscle infarction both in the anterolateral and the posterior medial pap muscle as well. So this new technique, I think, is going to be really optimal for improving the sensitivity of identifying small subendocardial infarcts, but also, I think, most importantly, for looking at the papillary muscles and looking for papillary muscle infarction. Now, so what is the mechanism by which this delayed enhancement technique works? So, because if you think about it, histologically, an acute myocardial infarction is very different than a chronic myocardial infarction. But yet, what I showed you, the data, suggests that it has the ability to identify what's viable and non-viable in both settings. And the reason, I think, has to do with the kinetics of gadolinium, which is if you look at normal myocardium with intact cell membranes, the volume of distribution of gadolinium, which again is an extracellular agent, so it doesn't enter into the myocardium, into the cells, but it just distributes within the extracellular space. In normal myocardium, where you've got nice, tightly packed myocytes, there's really very little extracellular space that's present. And as a result, there's going to be only a small amount of gadolinium molecules that will be present within any given pixel. Now, what happens in the setting of an acute MI? Well, you now have ruptured these cell membranes, and as a result, the gadolinium now can enter into the myocardium, so the total volume of distribution of gadolinium now is increased, and as a result, there's a higher concentration of gadolinium within any given pixel that has acute myocardial infarction. Now, what about in the setting of chronic myocardial infarction? What you have, or in the setting of non-coronary scars as well, is you have now this collagen matrix which has a fair bit of extracellular space within it. And again, as the gadolinium goes to all of this extracellular space, you now have more gadolinium within any given pixel. So although histologically acute infarct and chronic scar are very different, they both have a very common feature, which is that they both have a reduction in the amount of intact myocardial cells. And that's what this delayed enhancement technique is able to identify, replacement fibrosis or acute infarct that results from acute cell membrane rupture and acute cell membrane integrity loss. Now, one of the things, though, we know is that that's great for one form of myocardial fibrosis, but we know that, in fact, there can also be this diffuse myocardial fibrosis which can occur simply without a loss of myocyte integrity or replacement of the myocyte, but rather increased deposition of collagen within the extracellular space itself, leading to essentially an expansion of the extracellular volume much more uniformly. And so that then violates the basic need with delayed enhancement MRI, where you need to have a normal reference region and you need to have spatial heterogeneity. You need to have variability. And so that's where I think, and how often does this occur? In fact, this may be, this is one publication from Beltram where he suggests that roughly half of the extracellular matrix expansion in ischemic cardiomyopathy is actually deposited diffusely between myocytes as opposed to focally replacing myocytes. And so this is where now we have this newer technique called extracellular matrix imaging or extracellular matrix volume fraction assessment, which allows you to identify really the presence of expansion of the extracellular space, which may be much more diffuse in nature than our standard delayed enhancement MRI is able to identify. And so the way that this works, and again, it's based to some extent on the kinetics of gadolinium. And the way this technique works is the first thing that's going to be done is we're going to do a mapping technique where we can actually quantify the T1 value of the myocardium. And you can quantify the T1 value of the blood cavity. This is done before you give contrast. By doing this multi-parametric mapping technique, we then are able to determine what is a T1 of any given pixel within the myocardium and what is a T1 of any given pixel within the blood cavity. You couple that with what happens after you administer gadolinium contrast. Now we know that gadolinium is going to go to the cavity. It's also going to go to the myocardium, and the amount of gadolinium that's going to stay within the cavity we can actually easily compute, because we know that the extracellular volume of the blood pool is basically 1 minus the hematocrit. So if we know what the hematocrit is, we can know what the total percent of extracellular volume is within the blood pool. So we can see what the signal intensity changes within the blood pool before contrast and after contrast, and that's going to tell you the amount of gadolinium that's taken up by the blood cavity at any given time based on the change in T1. And then you can simply do the same thing for the myocardium itself. What is the T1 of the myocardium in the native state? What is the T1 of the myocardium after you give gadolinium? And the amount of contrast uptake by the myocardium will be directly related to the amount of gadolinium, which is directly related to the volume of extracellular space that's present. And then, and this is just showing kind of the equation that's utilized to compute this. But again, it's really based on that same basic principle, is that we're normalizing it for what the T1 changes are in the blood, because we know in the blood what the extracellular volume percent is within the blood cavity. And then obviously there's been several studies that have been done correlating this in animal studies with histologic specimens in mice, as well as in fact in humans with biopsy specimens that were obtained at the time of aortic valve replacement for AS, or in patients with hypertrophic cardiomyopathy that were undergoing septomyectomy. And there's also some data showing in the MESA cohort that the extracellular volume fraction actually is associated with age as well, so that there's a gradual progressive increase in the extent of extracellular matrix within the myocardium with aging. Now, obviously, this has been utilized in a number of different conditions. We have work undergoing looking at a large cohort of clinical patients to see if there's value in this extracellular volume fraction assessment above what you can identify as predictive value with the standard delayed enhancement MRI technique. And so I think to conclude, with regard to extracellular matrix expansion imaging, it appears to be correlated with the presence of increased interstitial fibrosis, that it appears to be associated with adverse outcome, and that this may be in the future a method by which we can monitor effectiveness of therapies that are designed to look for reduction in interstitial fibrosis, such as, for example, diastolic heart failure, such as in a variety of other conditions as well. So I think this is a technique which I think potentially has many, many applications, and we'll hear about more uses of this technique in the future. Now, let me kind of bring us back down to earth for a second and talk about what about today. I think one of the areas that CMR, I think, is really gaining more and more traction is in the area of valvular heart disease. And obviously, these are the American Society of Echo publication, the guidelines for assessment of native valvular regurgitation. And what's interestingly is now it also incorporates, it's a joint statement by the American Society of Echo and the Society of Cardiovascular Magnetic Resonance, and actually identifies scenarios where CMR could be useful in patients with valvular heart disease. And obviously, the initial assessment is going to start out with echocardiography, but then there's certain specific scenarios where we need to be careful of. And I think some of those are highlighted down here at the bottom. One is when you have very eccentric wall-hugging jets. The other is when you have non-holosystolic mitral regurgitation, such as in the setting of mitral valve prolapse, where the severity of the mitral regurgitation may change between early systole, mid-systole, and late systole. And then also, in cases where there's suboptimal echo images, or in cases where there's a discordance between the quality or between the imaging parameters by 2D echo, by spectral Doppler, and the history and physical exam. So, and so this is kind of a little schematic of kind of what are the scenarios where CMR could be helpful in valvular heart disease. And again, I think this just highlights the fact that I think CMR is really beginning to gain traction in this arena. And in fact, probably, of the cases that we do in our lab here, probably a quarter of them are now for valvular heart disease. One is if you have a technically difficult echocardiographic image. The other, obviously, is when there's a discordance between the history, the physical, the 2D echo, and the Doppler findings. And so, for example, if you have what looks like a mild amount of mitral regurgitation, but you have a very large cavity, that's a clue that maybe there may be something else going on. Maybe the severity of the MR may be worse than what you're seeing. If you have very eccentric mitral regurgitation jets, if you have non-holosystolic MR, as is shown in the TE example on the upper right-hand side, where you can see the severity of the MR is changing over the duration of the cardiac cycle. And then also when there's multiple jets, when there's mixed mitral regurgitation and aortic regurgitation, CMR could be useful. And then when there's a question not so much about the severity of the regurgitation, but rather about the consequences on the heart itself. So looking at remodeling of the ventricle, CMR can be helpful in that setting as well. For quantification of volumes, quantification of EF, assessment of myocardial viability, as well as myocardial scar. So another condition I think that has been a problem or an issue in the last few years is the concern now with gadolinium-based contrast agents in patients who have significant renal impairment. And what we now know is that for patients with a GFR less than 30, we want to be cautious about the use of gadolinium-based agents. Now, more recently, the American College of Radiology has actually kind of classified agents based on their presumed risk of NSF, with high-risk agents and agents that are thought to be not as high risk. And then, today in our practice, we don't use any of the high-risk agents, but we're using agents that have demonstrated a fairly low incidence of NSF. But again, I think it's something that we need to be cautious of because we know it can be a fairly serious condition. And what it poses as a problem for patients with significant renal impairment is to what are the options for vascular imaging in these individuals. keep going here. And so, MR has had a technique called time-of-flight MRA, which doesn't require contrast administration, but it does suffer from some limitations. One is it requires the vessel of interest to be perpendicular to the slice that you're imaging. It can cause problems with slow flow, which can cause signal void artifacts mimicking a stenosis. And then tortuous vessels also can cause a signal void mimicking a stenosis. And so, I would certainly not try to sell any of you on this time-of-flight technique, because I think you can see the image quality here is okay, but it's not by any means spectacular. And so that's where I think the advent or the use of ferumoxytol, an iron-based agent, which is actually indicated, in fact, for patients with iron deficiency anemia who have renal failure. So we know that it's in fact indicated for patients with renal failure because it has a very small amount of free iron. Most of the iron is chelated. It can actually be given as a fast IV infusion, which I think is one of the things that sets it apart from other iron-based agents which have been around, but which are not really well tolerated at a faster infusion rate. And here's an example, because it also has paramagnetic properties, so it gives you signal enhancement. Here's an example of a MRA which is done with iron-based agent versus one which is done with gadolinium. And if I show you these two, and I don't tell you which is which, I think you'd have a hard time being able to tell which is iron-based agent and which is which is gadolinium. In fact, the one on the right-hand side is gadolinium, and the one on the left-hand side is with the use of this iron-based agent. Okay, so let me say that now I think with the use of this iron agent, I think renal insufficiency is not really a limitation for MR imaging for the vascular system. So we can do, in addition to non-contrast imaging, we can use iron-based or ferumoxytol-based MRA to give us a very crisp assessment of the vascular system. Now notice this doesn't apply for scar imaging. This is only for vascular imaging, for luminal imaging essentially. Now, what's another area where patients have historically had contraindications to getting an MRI scan, and that's patients with implanted cardiac devices. And there's really a number of concerns that exist. One is a concern of heating of the lead tips themselves. The other is causing unintended cardiac stimulation. And then third is a concern of having device interactions. Now, this is becoming a bigger and bigger problem, because if you look at patients that get a device implanted, within 2 years after device implantation, there may be as high as 1 in 5 patients who ultimately have a need to undergo an MRI for some diagnostic reason. Skip past this. And so that's why in the last few years, industry has been hard at work at trying to develop MRI devices that are what we call MRI conditional, which means that the device can actually undergo, or the patient can actually undergo MRI imaging. The first one that came out was a Medtronic Revo with a SureScan pacing system in 2011. And this was approved based on a multi-center randomized controlled trial, which was designed to look at safety, as well as MRI-related complications and pacing, capture, and sensing amplitude thresholds. And they looked at close to 500 patients and then randomized them after getting the device implanted to undergo an MRI in half, and the other half did not undergo an MRI. And then they went and looked to see were there any complications. And what they found was that there were no major adverse complications, i.e. no sustained atrioventricular arrhythmias, no episodes of asystole, no episodes of pacemaker output inhibition, and no episodes of electrical resets in the group that was receiving MRI imaging. There was some minimal changes in pacing capture threshold that occurred. And so really this led to, I think, the approval of this device, which I think was great for patients that going forward were going to get this device implanted. But there were a couple of limitations that this device had. One is they did not look at thoracic scanning. This was only a pacing system, so it didn't look at defibrillators. And then thirdly, what about all those patients that had devices put in before this device was approved, which was millions and millions of patients that were out there. This didn't address that need at all. Now, in the second generation device from Medtronic, the Advisa, They did look at thoracic imaging, so eliminated the non-thoracic limitation. So thoracic imaging could be done with the second generation device as well, but it still didn't address the other two. And then a couple years later, Biotronic came out not only with a pacemaker, but also with a MRI conditional ICD, and the Medtronic also in the same year came out with an MRI conditional ICD. So now going forward, there's both MRI conditional pacemakers and ICDs that are approved for use in the United States. But again, still doesn't help us with all these patients that were done before these devices came out who may need an MRI scan. And so that's where we were actually involved in this study called the MagnaSafe Registry, which was looking at 1,500 patients that had a clinical indication for an MRI, but that had a device that was not MRI approved. And this was published last year in the New England Journal. And really it showed that there were no evidence of death. This was 1,000 patients with pacemakers and 500 patients with ICDs. In no cases of death in the pacemaker or the ICD group. No incidence of generator fail in the pacemakers. There was one generator fail in the ICD group. No instance of lead failure. No instance of loss of capture of pacing in those patients that were pacer dependent. Some occasional arrhythmias were observed, but that's not necessarily unexpected. And so overall, I think the results of this study really show that at least in a 1.5 Tesla environment, which is what this study was done at, in patients that were undergoing, for this particular protocol, it was non-thoracic MRIs, using a specified protocol to interrogate and reprogram the device, that this could be done in these non-approved devices in a reasonably acceptable fashion. And I think this is leading, obviously, hopefully, to a change in the CMS coverage decision with regard to approval of patients with implanted devices. One of the things, though, I think I want to keep you aware of is keep in mind that what was looked at here was specific scenarios. And the reason this is important is, I'm going to kind of digress for a second, but I think this will actually bring the point home, which is, how many of you have been to Vegas, Las Vegas? Not many, or you're not admitting to it, one or the other. So there's a hotel complex called the Vdara Hotel. And a few years ago, can you guys hear it?
Has been found to contain
volume up?
An extra you definitely...
Let me just start this again. Can you turn the volume up? I've got this loud as I can hear.
Thinking of taking a road trip to Vegas, be warned. The new MGM hotel there called the Vdara has been found to contain an extra you definitely don't want. It turns out when the sun's rays hit that curved building, it creates a 15-foot wide hotspot on the ground that is so brutal it can burn hair and skin and even melt plastic. Some unlucky hotel guests have been sent running from the pool area after being caught in what hotel employees are calling the death ray, a burning sensation from above. The hotel is rushing to fix the problem.
So what happened? So, obviously this is a multi-billion-dollar building, and you've got, I'm sure architects galore and engineers galore that are designing this, but this building had a lot of glass, and it was a curved glass building, okay? Not too much different than our Research Institute building, right, which has a nice curvature to it. But again, based on the height, based on the curvature, within not every day of the year, but actually just a certain part of the year, a few days of the year, a certain time of the day, between I think 10 and 12 o'clock, everything just lined up perfectly such that these sun rays actually became directly focused onto a small little area within the pool. And as a result, that caused excessive heating, and you have people that are getting burned. So this wouldn't happen, probably 360 days out of the year, and it would only happen, a couple of hours of the day. But what this, I think, brings home is a concept that you can't possibly test for every single permutation that exists. And so although these devices that are MRI conditional have been approved based on some clinical studies and a lot of mathematical modeling that's been done, it's not possible to take into account every possible scenario. And as a result, you still need to make sure that we monitor these patients very carefully. As a result, also, that's why the FDA has moved away from this previous nomenclature, which was the device is MRI safe or unsafe, to rather a 3-tiered nomenclature, which is MRI unsafe, MRI safe, and then what they call MRI conditional. Now, MRI unsafe is easy. It's not safe. You can't do it. Okay, that would be example that's a pair of scissors or an oxygen tank, right? MRI safe is actually anything that has no known hazard in any kind of condition at all. So really, the only thing that's going to be MRI safe will be something that's like plastic, has no metallic components to it at all. So maybe a plastic petri dish you could call MRI safe. Most things now they call MRI conditional, and then what that means is that an item's been demonstrated to pose no known hazards in a specified MRI imaging environment with pre-specified conditions of use. And so therefore, you only want to do it in those pre-specified conditions of use. And so what does that mean? You can actually go to a website called MRIsafety.com, and it lists every single device that's out there. And it will tell you, hey, this device has been tested in 1.5 Tesla or at 3 Tesla. It's been tested for thoracic imaging, not for thoracic imaging. And you really want to make sure that you're only doing it in the conditions that it's been tested for. And if you're doing it outside of those, then you need to be very cautious and make sure you monitor the patients very carefully. And in fact, even if you're doing it in the conditions that it has labeling for, if it's MRI conditional labeling, that doesn't mean it's 100% safe for MRI imaging. It means that it's thought to pose acceptable risk, but you still need to watch and monitor the patient very carefully. Okay, so let me skip forward now, I think, to an area of the future. So, probably the biggest complaint that we get from patients as well as referring doctors is the amount of time that it takes to do an MRI scan. So MRI is fundamentally a slow technique. So whereas CT could do your imaging in 10 or 20 seconds, MRI is going to take much, much longer to do that. Now, are there ways with MRI that we can speed up the imaging, right? And that's what the real goal is, I think, for the next decade in MRI imaging. So there's a thing that you can do called undersampling. So if I think of it that to generate my MRI image, I needed to generate all of these particular lines of data, I can actually do something where instead of imaging every single line of data, which takes time, I can image every other line of data. And if I do that, I've cut my time of acquisition down quite substantially. And now with the advent of newer MRI systems with multiple coil elements, you can actually sample every other line, but fill in some missing information based on the fact that how does something look to this coil that's situated over here versus a coil that's situated over here. So you can actually determine some information based on differences in what's being visualized from one location versus the other. And so here's an example of where we use what we call parallel imaging to accelerate our imaging. So upper left is what's called a real-time cine acquisition, and this is done with no parallel imaging. So I'm acquiring every single line of data, and this now gives me about 7 frames per second. So that's a temporal resolution of about 130 milliseconds. So that's not really that great, right? Now if I apply a 2-fold acceleration scheme, now I'm able to get to 14 frames per second. So I'm keeping the spatial resolution the same, but I'm improving my temporal resolution. So I'm able to get each frame in a shorter time period and therefore more frames per cardiac cycle. Now here's one where I do 3-fold acceleration, so I'm only acquiring 1/3 of the lines of data, and now I'm able to get 21 frames a second. And then on the right-hand side, I've now accelerated 4-fold, so I'm only actually acquiring 25% of the lines of data. Now I'm able to get 27 frames a second. Now, if you look at this image here versus this image, in this case, I kept the spatial resolution the same, but I'm adjusting the temporal resolution so I get more frames per cardiac cycle. You could then trade off in a different way. You could keep the temporal resolution the same, but try to improve the spatial resolution and make the pixels all smaller. But what inherently do you notice the difference between this image in the upper left versus this accelerated image in the lower right? Or nothing. Does it look the same? So obviously I told you that the spatial resolution is the same, but the temporal resolution is different. But what about the noise in the image? Does one image look more grainy and noisy compared to the other image? And to make it easier on you, look at the upper left versus look at the lower right. Or maybe, does this screen not project very well? Yeah, I mean, if you look at it, this image looks much more smoother, right? This looks much more speckly and noisy, right? There's more noise, okay? And that's what happens when you do more undersampling and more acceleration, your signal to noise goes down, all right? Now, because the reality is I could do, instead of 4-fold acceleration, I could go 10-fold or 20-fold. And I could cut my scan time down quite substantially, right? So, let me skip forward here. So that's where this concept comes in of utilizing a methodology called compressed sensing, okay? Now it's a bit complicated, and I don't want to put people to sleep, and I know I'm going to put you to sleep probably, but I'm going to give you kind of a high-level overview of what this does. So this is basically a way, so the basic theory is that you know that signals or images can actually be recovered from significantly smaller amounts of samples than conventionally required. Much, much smaller samples, okay? Because the unique thing about MRI is that the actual image data that you acquire, the raw data, is in what we call K-space. And every line of K-space somehow contributes to the formation of the image. So you can actually reconstruct an image which a much smaller fraction of the data than required to sample every single line of imaging data. But to do that, there's a couple of things that you want to do to really be able to do very high levels of acceleration. Not 2, 3, or 4-fold, but much higher when we're talking about 10, 20-fold levels of acceleration. And so this is what we're showing you here, right? So this is if I acquire every single line of data, if I acquire every other line of data. Now, if I acquire 1 in 10 lines of data, 1/10 of the lines of data, if I acquire every 10 lines, the problem will become that by missing all these lines, I actually will introduce certain artifacts. And the types of artifacts that get introduced are what we call these wraparound or fold over artifacts, where the outer part of the image actually folds over on top of the inner part of the image, right? And so that's where, with compressed sensing, there's 3 basic principles that are utilized. One is this idea of incoherent subsampling. What does that mean? So that's a fancy, I mean, the one thing is that these MRI PhD physicists like to come up with fancy terminology, right? Well, if you break it down, all it really means is, what does subsampling mean? It means I sample only a subportion of all the data, right? So I'm not sampling everything, I'm only sampling a part of it. Now, what does incoherent mean? Maybe what this entire talk about this is seeming like. It's incoherent, meaning that it's random, right? I'm not sampling every 10th line of data or every 5th line of data. You're sampling in a random fashion, okay? The second aspect, and we'll kind of go through these 3 in a second, is this idea of transform sparsity, okay? Which is that I've undersampled, so I've got sparsity of data, but there's a way that you can transform this data to filter out some of the noise. And then the last step to do that is by doing a technique that's called nonlinear iterative reconstruction, where I'm going to basically now take differing subsamples and try to generate my image and try to reduce the noise, but I'm going to do it in such a way that I can pick the one that turns out to be the best. Now this last piece, I think, is what the advent of computer processing power allows us to be able to do. What does iterative reconstruction mean? Well, it means you just keep doing it over and over and over again, right? So whereas, as humans, we tend to try to think of, let's try to solve the problem. A computer can just simply try every single possible permutation there is, and it can identify, okay, which is the one that gives me the best balance between a reduction in SNR without a loss of image quality. And that's what iterative reconstruction is doing, is that you just have a lot of GPU power, and it's just trying it out multiple different ways, right? The best example you can think of is computer chess player, right? Whereas the chess masters, they have a strategy. A computer, all it does is simply says, let me just try out, if I'm at this point in time, I'm going to try 100 or 1,000 or a million different possible permutations and see which one, 3, 4, 5 orders down, gives me the best outcome, and then that's the move I'm going to make. And so that's what this is here. So this idea of Irregular sampling is shown here, where again there's not a regularity to it. So it's sparse sampling in the sense that I'm undersampling, but I'm doing it in a fairly irregular fashion. And then obviously, if I don't do it in an incoherent or random fashion, I start to get these wraparound artifacts, overlay artifacts. But instead, if it's done in a very random fashion, you just get noise superimposed upon the image. And then that noise can then be gradually removed from the image in an iterative process using a lot of GPU power. And now, with the advent of high power computing, you can actually do this. And so this is an example. Let me see if this plays for us. No, it's not going to play. On the left-hand side is basically where I just did undersampling. And you can see the image looks fairly noisy. On the right-hand side is where you do undersampling or sparse data collection, but then you do some regularization, and then you do multiple iterative reconstructions to identify the one that gives you the greatest balance. Now, what does this mean? It can really, so two things it means. One is that the acquisition time can be cut down quite substantially. So literally what used to take 8 seconds of a breath held to acquire a cine image could now be done in a 1 second acquisition, but it will require then 15 seconds for the computer to process and reconstruct the image. So you've basically transferred image acquisition time now to computing processing time, which is fine because that doesn't matter if the patient moves during the other 14 seconds while the computer is reconstructing. You just need the patient to be able to hold their breath or stay still for the 1 second that it requires to do the image. And there's actually some head-to-head comparison studies that have been done looking at, if we just simply look in the basic application of using this for cine imaging, looking at ejection fraction calculation using the standard breath-held cine imaging technique, which again, if we acquire every single slice, would take us about 10 minutes to acquire, versus using a compressed sensing technique where you can acquire it all within one single breath hold or within a series of 1 second breath holds. And you can see that the EF calculations are very spot on by the standard methodology versus the use of this newer compressed sensing technique. Now, obviously, this is just the tip of the iceberg. So this is a kind of a new technology that's just been approved that we're just waiting to get it installed here. Obviously, the first application, the simplest application, is to use for cine imaging, but the next generation of this is going to use this for everything else, for delayed enhancement imaging, for doing 3D volumes of the heart, for doing things like 4D flow imaging, but in a much, much faster fashion. So I think the whole goal, I think, of having this backbone developed now is that we can essentially speed up the acquisition time of most of the MRI imaging techniques on the order of 5 to 10-fold shorter duration. So to kind of wrap up, I think a few things. We talked about the fact that MRI is great for identifying focal replacement fibrosis, and I think it's a new tool for identifying diffuse myocardial fibrosis as well. That these newer iron-based agents now give us the ability to do vascular imaging in patients who can't get gadolinium because of renal failure concerns. That we have now new MRI conditional devices that are FDA labeled. And lastly, I think that what we're going to see is the speed of imaging with MRI is going to get faster over the next decade as we utilize these new compressed sensing algorithms. So let me stop there and open it up for any questions or comments. Okay. All right. Thank you.